Hello, my name is Jennifer Klemp. I am a professor of medicine in the Division of Medical Oncology at the University of Kansas Cancer Center, and I also work for Caris Life Sciences. So it's often asked, what types of patients should we test for hereditary cancer syndromes? Of course, the most common are BRCA1 and 2, but should we be testing for other genes? And so as we think about that, I think one of the most important pieces is that certain types of cancer have a single indication sort of reason or recommendation of why we would test. For instance, triple-negative breast cancer, younger ages of breast cancer, metastatic breast cancer, in particular those who meet certain criteria from previous clinical trials, patients who have family histories, any patient with ovarian cancer, any patient with pancreatic cancer. So I think that as we think about sort of the single indication tests, that is the first level. But then the second level is, okay, outside of BRCA1 and 2, like why would we test patients and what's that going to tell us? Well, there are a lot of other mutations that as we've been doing larger types of panels, a wider net, kind of a deeper depth and breadth of testing, we're finding mutations that are called moderate penetrant. So they are high risk, but maybe not as high as BRCA1 and 2. We find that some are more frequent, frankly, in some populations, but they can confer not only risk for breast cancer, but other types of cancer, like colon cancer, ovarian cancer, melanoma, etc. So I think the important part is that really single syndrome testing, where we just look at one or two genes, is really not common practice anymore, and it frankly hasn't been, in my opinion, for quite a bit of time. But we should be doing panels that are appropriate for the patient population that we see. And you want to make sure, in most cases for germline, that there's an actionability or it's tied to kind of a known risk of cancer, and then what would we do about that with screening? One of the challenges of not using a larger panel is that sometimes you don't know what you don't know. And I think that history kind of informs us that we didn't know about certain conditions when we didn't test using a larger panel. So for instance, if you take a patient with lobular breast cancer, maybe we find that they have a CDH1 mutation. That's very common with other types of cancer, in particular cancer of the stomach. So why would we, necessarily test a patient with breast cancer for something that isn't always associated with it? So that's where doing a larger panel is going to help us identify mutations that traditionally, if you look through a narrow lens, you're not going to find. But now you're going to find it. And a patient who has a risk of gastric cancer, that's really important to know, as is their risk for breast cancer. So I think the important part about using a larger panel and not doing single syndrome is that it really gives us the risk of the whole patient, helps us help that patient, and then it allows us to take that information that we've gleaned from the patient and deploy, as we would like to say, cascade testing, or testing those individuals that are first-degree relatives, sisters, brothers, children, parents, those that have a direct linkage to that patient, so that we can determine what their risk for cancer is too. It's always hard when you have a cancer patient sitting in front of you, you're doing testing, and you're having to react to a diagnosis. So a lot of our patients are very motivated to find out this information so that their loved ones can kind of have additional screening, maybe do some preventive options so that they won't have to deal with a diagnosis of cancer.